Hi there, Dr. Abdul El Sayed here. I'm a physician, epidemiologist, progressive activist, and co-author of the new book, Medicare for All, A Citizen's Guide. I want to talk today about why Medicare for All would help to address the shameful health inequities that we have in our country and is critical to addressing anti-Blackness and taking on structural racism in America. Well, first, I want to start with a startling fact. We are in the midst of a pandemic, and that pandemic has taken 2 to 3 times as many Black lives, depending upon what state or city that you're in, as it has white lives per capita. And that fact should astound us. But here's the thing. If you've been watching anything relative to health inequities in our country, you know that this is nowhere near new. Think about any healthcare issue that we could talk about. Infant mortality, death at the beginning of life, 2 to 3 times as likely among Black babies versus white babies. Think maternal mortality, 2 to 3 times as likely. Think asthma exacerbations. Think diabetes hospitalizations. All of them far more likely among Black Americans versus white Americans. And I want to talk a little bit about why this is. Let's focus in on the COVID example here for a second. We've got a virus, and we know that that virus causes a particular pathology in humans. But it's not just about the virus. It's about the way that the virus interacts with a particular host in a particular environment. And what we've got in America right now is a virus that has been tackling hosts who have been beaten up on by the environment. When we think about structural racism and the ways that it shapes our lives, it influences where one grows up, who one's parents are, the probability that one's parents have been justice involved. Think about the water that people drink. Think about the air that people breathe. Think about the housing that they live in. Think about the jobs that they work. All of them systematically shaped by structural racism. And so this environment, this structurally racist environment, has been beating up on Black and brown people in our country for a very long time. It's the reason why the baseline risk of underlying conditions, things like hypertension and high cholesterol and obesity and diabetes, are substantially higher in Black and brown Americans than they are in white Americans. And then in comes the virus, and it walks a path just like these other diseases so that it affects Black and brown people more. They're more likely to get it and more likely to die of it. Now, when we think about the role of health care, I want us to differentiate between health care and health. Health is a function of illness, but health care is supposed to be that set of institutions that prevents illness and treats illness once we have it. And unfortunately, health care is also just as inequitable, if not more inequitable, than the circumstances of disease that we're talking about. So rather than be a salve for the systematic increase in the likelihood of illness as a function of structural racism in the environment, in fact, it helps to perpetuate it. And that starts with the insurance industry. Think about the fact that if you don't have public insurance, whether it's Medicare for seniors or Medicaid for low-income folks, that you're likely to be insured if you have it through an employer, which means that if you're less likely to work in a job that provides health insurance, or you're unemployed, you're less likely to be insured. And in this circumstance, when we know that race affects the schools that people go to, the jobs that people work, the income that they make, of course, if we rely on the employment sector to provide health insurance, that it's going to be less common among Black and brown folks. And lo and behold, we know that Black folks in America and brown folks in America are far more likely to be or underinsured. They're more likely to have to pay a high out-of-pocket cost if they get care, and they're more likely to be on Medicaid. Now, Medicaid is a program that is supposed to address that fact. But here's the thing. We know that programs that are tiered, that specifically are created to provide services for poor folks, are a recipe for poor programs. Medicaid does not reimburse health providers the same way that private insurance does. And so what tends to happen is in low-income communities, particularly Black and brown communities, you have hospitals that are disproportionately reimbursed on Medicaid, which means that over time, the lack of money that they get because of that high proportion of Medicaid patients tends to leave them without the resources that they need. And so we know that Black folks, even in the same cities, are more likely to go to hospitals that are under-resourced and where outcomes are worse. And so it's not just about health insurance, it's the way that health insurance patterns access to healthcare itself. I mean, this is a problem in rural communities too. We know that rural community hospitals are being hollowed out because a high proportion of those patients are Medicaid patients. And because of the low density of people, you just don't have enough money flowing into those healthcare institutions and they shut down. Think about the hospital in the community where I used to be health commissioner, the Detroit Medical Center. Detroit Receiving started out as a public hospital. And over time, it became a nonprofit hospital, and now it is a for-profit hospital. They got in trouble 4 years ago because they could not wash their surgical instruments correctly. They weren't autoclaving those instruments, and they were causing the infections. And it's the way that our private health insurance system that is relegated to only those who have income patterns the resource flow into hospitals that then patterns the kind of healthcare that people get or don't get. So it's not just that Black and brown people are less likely to be insured or more likely to be underinsured. It's also that the hospitals that they attend, as a function of that uninsurance and as a function of that requirement of having to be on Medicaid, those hospitals tend to be under-resourced as well. And then there's the treatment that people get in hospitals, whether it's conscious or unconscious discrimination. We know that that is a serious issue. Part of that is the fact that we have fewer Black and brown doctors in the healthcare system. And that is a function of the way that structural racism shapes in educational opportunities and debt burdens. We, in fact, authored a paper called The Color of Debt, where we looked at the differences in the debt burden of Black medical students versus white medical students and found that they had significantly higher debts. And those debts become a paywall that then keeps too many promising Black and brown students away from medical school. So we have to address that. But then there's also the way that bias is pernicious in the ways that institutions treat Black patients. And the stories are profound as they are sad. Now, how do we address that? Well, Medicare for All could help to address that too. So I want to talk now about Medicare for All, why it is a key to this solution. Number one, Medicare for All would provide health insurance to every single American. That means that no longer would we see these disparities in health insurance access that are so critical. And second, it would be the same health insurance. The reimbursement that comes with paying for healthcare for your body, whether you are Black or brown or white in America, will be the exact same, which means that the process by which lack of health insurance and Medicaid then leave hospitals and clinics that disproportionately serve Black and brown people under-resourced, that goes away because the reimbursement that comes with your insurance in Medicare for All is exactly the same, which means that you now have resource flows into hospitals that treat predominantly Black and brown communities in the same way that you have resource flows into hospitals that don't. And then when it comes to thinking about medical school, well, we know that Medicare right now actually pays for physician training after medical school. Why is it that Medicare under Medicare for All couldn't pay for all of medical school? In fact, if we were to do that, it would take away the barriers that too many promising Black and brown students face to getting into medical school, and we could increase the diversity of the physician pool to help to address that issue of bias in the clinic. We know that patients, Black and brown patients who see physicians of color tend to do better over time. And then lastly, it's possible that reimbursement rates could change based on whether or not a certain hospital is treating enough Black and brown patients relative to the local community, or how their outcomes fare relative to white patients. And you could imagine, right, that under Medicare for All, because you have one payer into the system, that you could toggle those reimbursement rates based on how well these hospitals perform. So you create an incentive to address any systematic bias that is either keeping Black and brown patients out or leaving them to be treated worse than white patients. And so Medicare for All can help to address the systematic differences in insurance access, systematic differences in hospital resources, and both conscious and unconscious bias, because it allows us to focus in and treat every single body the same way. Now, I want to finish on a final note. Truth of the matter is, the hospital industry, the pharmaceutical industry, the insurance industry, they are fighting tooth and nail to defeat Medicare for All. And they're systematically trying to alter the facts on the ground. But here's the thing. I want to remind you a little bit about our history. Medicare itself, the program for people over 65, you know what tactics the AMA and others used to try and oppose Medicare? They fearmongered, played to racism, because they told, in particular, folks in the South, white folks in the South, that if Medicare passed, it would desegregate hospitals. And those folks fought tooth and nail to oppose the passage of Medicare. We know what happened there. Medicare passed, and in fact, hospitals were desegregated. It was a critical moment for healthcare in our country, a critical blow to anti-Blackness. But here's the thing. The same forces are trying to fearmonger. They're trying to tell us that if we passed Medicare for all, that the system would take away choice, that the system would cost too much, and that people who are hanging on by a thread onto their services would lose those services. In fact, I've heard folks say, well, if Medicare for all passed, I'd lose my Medicaid. Well, you get a fantastic upgrade in what Medicaid offers if, in fact, we had universal public health insurance for everybody, which is what Medicare for all would offer. And so we've got to step up against the forces of moneyed interests in healthcare to take on that fear mongering that tells folks that somehow the system would get worse if we guaranteed every single person, no matter the color of their skin, access to high quality government health insurance, just like everyone else. We've got the opportunity to do that work. I hope that you'll check out the book that I wrote with my co-author, Dr. Micah Johnson, Medicare for All, A Citizen's Guide. We talk a bit about these issues and so many others in the book. I hope you'll check it out, medicareforallbook.com. You can also access it at the conference website just here. So I really appreciate the opportunity to talk about the role that Medicare for All would play in taking on systemic racism in healthcare and addressing health inequities in our country. I believe deeply that this is what we need to do, and I hope that you'll consider checking out the book and continue fighting for Medicare for All. Thank you.
Greetings, my sisters and brothers. My name is Martese Chism, and I have been a registered nurse for 28 years, currently caring for patients in Chicago. I am also a proud board member of National Nurses Organizing Committee, an affiliate of National Nurses United, the largest union of registered nurses in the United States. As nurses, we make an oath to protect our patients. And the reality is that my colleagues and I have to protect patients from our own healthcare system. That's why nurses have been working for decades to achieve Medicare for all and to bring to life a more humane healthcare system based on patient needs, not on suffering and private profit. The intersection of healthcare justice and racial justice is critically important to us, especially as we see firsthand on a daily basis the disproportionate impact of the COVID-19 pandemic and our profit-driven healthcare systems on communities of colors, on our patients. Before COVID hit, even with the ACA having passed in 2010, over 29 million Americans were uninsured, and a minimum of 44 million were underinsured. Amidst the pandemic-induced recession, it is estimated that nearly 100 million Americans cannot get the health care they need. Before the onset of COVID, so we know these numbers are considerably worse approximately 4.1 million African Americans did not have insurance. Approximately 9.1 million Latinx did not have insurance. 6.8 million of them are undocumented immigrants. People of color are less likely to have employment-based health insurance, less likely to be able to purchase it on their own. Even when Black, Indigenous, and other people of color patients do have insurance, we bear direct witness to the heart-wrenching decision they and their families are forced to make because they cannot afford the care they need. People of color pay a much larger portion of their income on health insurance premiums, co-pays, and deductibles than white counterparts. As a nurse, I am intimately aware that our current healthcare system fails our patients and reinforces the racism, xenophobia, and classism against which our nurses union stands wholeheartedly against. During this COVID-19 pandemic, I have seen patients come to our emergency room in severe COVID distress. They stayed at home because they were uninsured. Everyone here knows by now that Black, Indigenous, Latinx, and Asians are disproportionately affected and die from COVID-19. Black and Latinx Americans are 3 times more likely to become infected with COVID-19 than white Americans. Native Americans, Blacks, and Latinos are being hospitalized from COVID-19 at around 4 times the rates of whites and are dying from COVID-19 at about twice the rates of white people. And the number of Asian Americans dying from COVID is on the rise. An article in the July publication of Health Affairs stated that in San Francisco, Asian Americans represented half the COVID-19 deaths, though they are only 1/3 of the population. Multiple generations of racial health disparities created by a racist society and shaped by a racist healthcare system render us more vulnerable to getting COVID and dying from it. This discrimination extends to the lack of protection of frontline healthcare workers. Both our healthcare system and our elected officials have failed to ensure that nurses and other frontline workers have even the most basic level of personal protective equipment, or PPE. As of December the 30th, over 590,000 healthcare workers have been infected. 283 registered nurses and 2,593 healthcare workers have died from COVID-19, a disproportionate number of whom are BIPOC. Filipino nurses, in particularly, have been hit hard. About 1/3 of the nurses who died from COVID in the US are Filipino. Even though Filipino nurses make up just 4% of the nursing population. Most of these deaths could have been prevented had our elected officials and hospital employers taken appropriate steps to protect us. We nurses are beyond outrage and have been organizing more ferociously than ever to get ourselves the protection we need to fight this pandemic. Over the last 11 months, nurses have held thousands of demonstrations at facilities across the country, demanded the PPA, regular COVID testing, and safe staffing that we need to safely take care of our patients. What we're up against is a profit-driven healthcare system that always wants to spend as little money as possible, even when it puts nurses and patients at risk. Medicare for All will remove the profit motive that endangers our lives and create a system based on patient needs and patient care. And it will ensure that optimum staffing levels and other protections are prioritized, centering the needs and creating safer conditions for patients, nurses, and other healthcare workers. We are in this fight together. And we know that when we fight back, we win. Under the leadership of our executive director, Bonnie Costello, herself a nurse and a woman of color, we drive the Medicare for All movement because we believe it is a significant step in the process of dismantling racism in healthcare. The fight for Medicare for All is a continuation of the legacy of the civil rights movement of the 1960s, when Medicare was instrumental in desegregating hospitals in 1964 as the Civil Rights Act was signed into law. My great-grandmother was a civil rights activist in Mississippi. She marched with Dr. Martin Luther King Jr. and Congressman John Lewis across the Edmund Pettus Bridge. She got into good trouble, necessary trouble, for voting rights. Now is the time for us to get into some good trouble, necessary trouble, for Medicare for All. If we are to address systemic racism in healthcare, it must be done through wholesale transformation. A first significant step in the right direction is passing Medicare for All and guaranteeing comprehensive medical care to everyone in the country. We have been able to grow support for Medicare for All by organizing and communicating our mission and sharing the goals and the vision of Medicare for All, goals and a vision only possible if we simultaneously pursue racial justice. If we are to win, it will take all of us.
Hi, I'm Dr. Victoria Dooley. I'm a practicing family medicine physician. I'm a healthcare activist, and I'm extremely passionate about eliminating health disparities. So I'm going to spend a little bit of time discussing Medicare for all, racism, and health disparities with you today. I'm so delighted for this invitation. The fact is racism shortens the lives and harms the health of Black people by promoting genes that lead to inflammation and illness. This is not a hypothesis. This is a fact. Scientific evidence proves it. So when you hear facts like African Americans or Black people have the highest incidence of hypertension in the world, and then when people say, well, maybe it's because of their genes, it's really frustrating to me, because we kind of got to go back to which came first, the chicken or the egg argument. Were we just born with genes that predispose us to hypertension? No, it is the systemic and institutional racism that changes our genes to predispose us to hypertension. And Black women specifically have the highest incidence of heart disease, all forms of heart disease in the country. They have higher rates of heart disease than Black men, white women. And when you think about all the stressors that we have to carry as Black women in this country, it doesn't come as a surprise. When I first heard the statistic as a Black woman, I was a little bit shocked. I couldn't believe it, because neither myself, my mom, or my sister have any form of heart disease. But as I started being a practicing physician, and I keep seeing all these young women in their 30s and their 40s and their 50s, beautiful Black women who had heart disease, the statistic started to come to life to me. Over 50% of Black women over the age of 19 have some form of heart disease. And so as Black women, what do we face? We go to work, we get paid 60 cents on the dollar. We are the most college degreed women in the United States, but we also incur the most student loan debt. When we go to work, we're policed for stupid stuff like our hairstyles. And not only do we have to worry about ourselves as Black women, but we have to worry about the Black men in our lives that we love. Our sons, our husbands, our uncles and fathers and loved ones. We have to worry about them being gunned down by the police and hunted by the police. And I use that term intentionally. So we have all these things to worry about. And not only that, right? There's this idea of a strong Black woman. And Black women absolutely are strong. But this stereotype of the strong Black woman makes us feel like we don't have the right to feel depressed, anxious, stressed, because that's a sign of weakness. So when you think about all we have to experience as Black women, it really makes sense that we are more likely to have broken hearts. And Medicare for all won't cure racism, right? But neither did freeing the slaves. Nonetheless, I'm glad that it happened, so I can sit here today as a free-ish Black woman. If your litmus test for whether or not something is a good policy is whether or not it cures racism, well, then you're going to be extremely disappointed all your life, because there is no one way that we're ever going to cure racism. But what Medicare for all can do is to put us on an even playing field. And the Medicare for all that I talk about, as part of the law, it makes implicit bias training mandatory. It will be mandatory for all providers to learn how to provide culturally competent care. It would allow patients to sue providers who did discriminate against them because of the color of the skin, who assumed that their pain wasn't real simply because doctors don't believe Black women when they have pain complaints. They believe our skin is thicker and that we have, less pain. The Medicare for all that I'm talking about is going to allow things like transportation to be covered, because too many people of color and people of low income have difficulty getting to the doctor because they don't have reliable transportation, or they might not live in an area with good public transportation. It's going to fund telemedicine. That's something private insurance companies weren't really doing universally until this pandemic, right? Because you have people who live in rural areas and their nearest doctor might be an hour away. So it's going to fund telemedicine for these communities, and it is going to fund new positions within the healthcare system, cultural competency care liaisons, to help make things more equitable. And it's going to bring down costs. It's going to bring down prescription costs. You're going to have no copay when you go to the doctor or the pharmacy or get your labs. Everything's going to be covered in full. And this is huge for everybody. But because people of color are more likely to disproportionately have diabetes, very difficult to control high blood pressure, it's going to help us a ton more because we are more likely to have conditions that oftentimes can only be controlled with expensive medications like insulin. So some Black people die because the healthcare provider didn't treat them with dignity and they had implicit biases, but some die because they could not afford insulin. This is people of all colors, but Black people are more likely to have diabetes. So just being able to get all your medicines covered in full is going to be life-changing for a ton of people, especially communities of color. And you know, with every effort that we've made to ensure more people in this country every single time, whether it be expanding the Affordable Care Act or expanding Medicaid, every single time, there is still a disproportionate amount of low-income people of all colors, Black and brown people, who are still left uninsured. Every single time. Call me a conspiracy theorist, but I do not believe this is a coincidence. It is intentional. They know that with all of these policies, there's still going to be a disproportionate amount of people of color who are left uninsured. And there's an easy solution to this problem. A grade schooler could figure it out. If you have some people who live in the wealthiest nation in the world who are uninsured, what do you do to solve that problem? You provide health insurance to them all, guaranteed as a human right. And so the solution for people of low income is not Medicaid. Medicaid is a great program. I'm glad that we have it. I feel saddened for people who live in states that didn't expand it. So right now, it's the best that low-income people have, right? But Medicaid is this scarlet M. It tells everybody that you are poor or low income, and nobody should be able to guess what your household income is simply because of some words on your card. And it restricts you. The patients that I cared for in Flint who were subsequently poisoned by lead water, yes, they can go to the doctor, but if they have Medicaid, there are a lot of doctors who don't accept Medicaid. There are a lot of medications that Medicaid won't cover. So they have health care, but it's restricted simply because of the word on their health insurance card. And that is not right. So in order to get healthcare providers to treat patients equitably, we must allow healthcare providers to treat patients equitably. Well, what does that mean, Dr. Dooley? Right now, doctors can't give patients the best care because we have health insurance companies that tell us as doctors what we can and cannot do. So you might have a patient and you might think one particular medicine is the best medicine for them, but if their health insurance doesn't cover it, you can't give that to them. So I think it is very important for us as a society to have one single payer where we can treat all patients fairly and equitably, where we as healthcare providers don't have to consider if this patient will be able to afford this medication. It's important to get healthcare providers in this mindset as a step towards eliminating health disparities and getting them in the mindset of treating all humans as humans and not just looking at their color. So right now, they look at the health insurance card to dictate what kind of care that they can give. And we need to eliminate that obstacle so that they can treat all patients fairly and then train them to eliminate implicit biases and move past individuals' color of their skin. So where do we go from here to get Medicare for all? We need to keep having discussions like this. We need to keep putting pressure on elected officials. We need them to know that if you run on Medicare for all, we are going to expect you to deliver and fight for it like hell, because it's literally a life and death situation. And if they don't, they need to know that they are going to only have one term. So America's healthcare system is neither healthy nor caring. It is not going to be easy to transform it because of these big muddied interests, but there is too much at stake, and we must continue to fight to not die because we are unfortunate to have an illness that we cannot afford. Thank you.
Hi, everyone. My name is Dean Robinson. I'm an associate professor of political science at the University of Massachusetts, Amherst. I serve on the board of MassCare, which is the single payer coalition here in Massachusetts. And I'm going to make offer some remarks on Medicare for All and racial justice, taking a bit more of a historical and political economy perspective. I want to make 2 points. That Medicare for All advances goals associated with the Black freedom struggle, or what was called the Black liberation movement by the end of the 1960s and early 1970s. And for most of the 20th century, this meant securing broad social and economic rights, including the right to bargain collectively in full employment, as well as robust anti-discrimination law and policy. Hamilton in their book, The Dual Agenda, and Teray Reid and Toward Freedom both get at this history in slightly different ways, but here again is the idea. From the New Deal period until the waning stages of the civil rights and Black power eras, it was the consensus view across the ideological spectrum that advancing racial justice meant universal social welfare policies, including healthcare. It meant economic rights, including collective bargaining and full employment, as I mentioned, and it meant federal hegemony over all of this. And it was universal policies that were thought to provide the platform through which we would then address racial and other forms of discrimination. This is an underappreciated history because of a false assumption, and that is that the civil rights movement and concerns about equality for Blacks in the United States focused principally around racial apartheid and discrimination. And this was never entirely the case. A. Philip Randolph, Bayard Rustin, Martin Luther King Jr., and other civil rights activists across the political spectrum viewed the status of Black Americans as linked to more general dynamics of inequality under US capitalism. Therefore, the only way to secure benefits for Black Americans was to win them for everyone. And this perspective could be seen, for example, in this 1944 publication, What the Negro Wants, edited by Rayford W. Logan. Same types of assumptions guided the March on Washington and the slogan, Jobs and Freedom. This march was orchestrated to give support to the Civil Rights Bill that was signed into law in 1964, but it was also in support of economic rights. First released in 1966, the Freedom Budget also captured this idea of a dual agenda of advancing universal social and economic rights, as well as laws and policies that target racial discrimination. So in the Freedom Budget, you can read proposals about a federal jobs guarantee, basic income guarantee, as well as universal health care. And even radical groups like the Black Panther Party saw racial oppression in the context of US capitalism. And so for the Black Panther Party, Black liberation required federal provision of a range of what we call social welfare items, as well as healthcare. And in addition, it required tackling racial inequality that was due to specific forms of racial oppression. The picture to the left shows Black Panther Party's free medical program for members of the community. So again, the point here is that there was broad consensus across a range of activists from the 1930s into the late 1960s that we need to aspire toward universal social welfare provision, broad economic rights, as well as targeted proposals and policies that address racial discrimination. Now, when we look back, this dual agenda idea was correct. When Black people enjoyed greater economic, social rights, health got better. Next slide shows how that's so. This comes out of a book project that I'm doing with a friend and collaborator, Javier Rodriguez. So here you're looking at excess deaths among Blacks under 55 years of age. This is capturing death rates above what should have been expected if Black people were dying at the same rates as their white counterparts, adjusting for sex and age. Notice that the slope is downward, and we estimate that the racial disparity would have disappeared by 2004 were it not for the Reagan Revolution. So why did racial health converge? Why the racial health convergence? Well, there was a broad set of policies that were enacted during this period. So we'd look at the War on Poverty, which had a number of anti-poverty programs, but it also led to expanded public sector job opportunities that were especially beneficial to Black women. This is a period of civil rights laws that formally ended racial apartheid. This was also 1965 when Medicare and Medicaid were enacted. This, of course, expanded healthcare access, but Medicare also pushed a swift desegregation of American medicine by being able to force hospitals and clinics to comply to Title VI of the Civil Rights Act. So again, by pushing broad economic, social policies, as well as anti-discrimination laws and enforcement, we saw a dramatic improvement in the health of Blacks relative to whites. So of course, this changes, as you can see, with the election of Reagan in 1980 and the social and economic policies that then follow. You see that excess death rates for Blacks increase very dramatically, and then they begin to fall in the period that corresponds to the Clinton administration. I want to point out that in the work that we're doing, we're finding that it's not that there were positive governmental programs or policies that pushed this convergence of Black excess mortality relative to whites, but it's rather that white health was declining, and that's believed to be due to the deleterious impact of trade policies like NAFTA and GATT on employment at the time. The thing I want to emphasize here, and it's a kind of obvious point, is that when we think about racial disparities then, or in the present context, this has nothing to do with mysteries of DNA. This has everything to do with trends in political economy and in social and economic policy and anti-discrimination enforcement. So Medicare for All can advance racial justice directly by providing healthcare access and quality. Medicare for All is a way to guarantee healthcare as a human right, and we can use the power of a single payer to enforce compliance with anti-discrimination law, as we've done in the past. And we can thereby ensure that healthcare is delivered in an equitable and appropriate fashion. Medicare for All has an indirect impact on racial equity in that it bolsters wages, which are affected by rising healthcare costs, as well as relieving public budgets. So whether you're talking about towns, municipalities, or state government, Medicare for All relieves public budgets and that is going to disproportionately benefit Black and brown people who tend to rely on not only public programs, but public employment. And so again, they're indirect ways that Medicare for All advances racial justice. We have a lot to do. We need to really push this within our unions and engage in broad community and public education campaigns. And of course, we have to advance the goal of Medicare for All at the state and or national levels. And so, again, I wanted to offer a historical overview, a kind of political economy overview about the importance of Medicare for All in advancing racial justice. And I will end my brief remarks with a quote from the Black Panther Party, all power to the people. Thank you very much.